Welcome to Raw Online. So today we are going to discuss a very important topic that is regarding your ischemic stroke. Okay, so this is a thrombectomy 6 to 24 hours after stroke with a mismatch between the deficit, that's the clinical deficit, and the infarct. Okay, so this is the very famous Dawn trial. Okay, so clinical question: in patients who are 6 to 24 hours post acute stroke and have a mismatch between the clinical deficit and the infarct, does thrombectomy plus your medical care compared to medical care alone improve the functional outcome at 90 days? That is, effective question is, can we do thrombectomy or not in a patient with a 6 to 24 hour ischemic infarct? Okay. So what is the background? The previous randomized trials have demonstrated that thrombectomy is of benefit when performed within 6 hours of stroke onset. And there is limited information on the effect of thrombectomy after 6 hours. Patients who have ischemic brain tissue that has not yet infarcted may benefit from reperfusion, as we already know. So these patients can be identified by a clinical deficit disproportionately severe relative to the volume of infarcted tissue on the imaging studies. Okay, so taking this as the background, we are going to evaluate, can a thrombectomy be done in patients more than 6 hours and within 24 hours. Okay, you receive a patient with an acute ischemic stroke, the time duration is 6 to 24 hours and clinically there is severe weakness. You are doing a imaging and the infarct which is seen in the image is not fully explaining the severity of the plegia basically. Okay, in that case you come to a conclusion that the severity of the plegia, that is a weakness, is more compared to what has already been infarcted. It means that there is a penumbra, there is an umbra and there is a penumbra, that is a salvageable ischemic brain tissue which can be revascularized. So this is what you come to a conclusion when the clinical deficit is very severe compared to the amount of infarct in the imaging. So this is a randomized clinical trial and a web-based randomization software, 1:1 randomization, that is equal number of participants in both the groups and stratifies according to age, mismatch criteria, time from onset and occlusion site. It is unblinded, open label trial. What is the meaning of unblinded? Meaning the participant and the researcher, both of them are aware what particular strategy is going on for both of them. And open label trial, meaning the participant is completely aware of what medicines or what intervention is he getting. Allocation concealment maintained during a randomization. Okay, what is the meaning of allocation concealment? Basically, until the time of allocation, they are not aware of which segment or which group the patient is going to get allocated at all. But after allocation, they are unblinded. They know what type of strategy, what treatment protocol are they going to undergo. Okay, this is called allocation concealment. For example, you are allocating a team to team A and allocating a person to team B. Till the time of allocation, they won't know what exactly they are allocated to. For example, team A, a group of people should get injection A and a group of people should get injection B. Okay, so they are in a set. Unless the injection box comes to the bedside, they won't know whether they are going to get injection A or injection B. This is called as allocation concealment. But once the box is arrived, you open the box, you see it's going to be injection A and you're going to give it. So once the treatment is offered, they know what is being offered. But till that very moment, they won't know what type of allocation are they going to get into. This is called allocation concealment. This is basically helps in avoiding selection bias in randomized controlled trials. Okay, for example, I'm going to conduct a trial. I have produced a vaccine, say an injection A. So I can choose a less severe diseased person, relatively a normal person, and I can choose them into my group, the group A, and I can give my vaccine and say that my vaccine worked well, right? So that kind of selection bias shouldn't be there. So this is called as allocation concealment, where I really don't know which patient is going to get which injection. But ultimately, once the treatment is offered, they'll come to know what treatment they are getting. So this is different from blinding. Blinding means even after the treatment is being given, neither the family nor the patient or the instructor will eventually know what treatment category he is on. Okay, this is called blinding and this is allocation concealment. The primary outcome assessed by blinded structured interviews in person 163 and telephone 43. Okay, and second primary outcome added, secondary from the secondary outcome, are 30 months. Whilst the trial is being blinded, following request from the FDA authorities. The perfusion diffusion imaging measures infarct and ischemic size were calculated by rapid software. and this is going to be an intention to treat analysis. So what is the basic of intention to treat analysis? Basically, you start a program, you start a trial, and you select, say, n number of population group B and n number of population group A. Okay, irrespective of what happens to them eventually in the due course, irrespective of whether they have followed the protocol, they have not followed the protocol, they have been left over in the middle of this in the trial, irrespective of all these things, you are going to compare how they started with. For example, a team A has 400 people and team B has 400 people. You are going to just compare 400 versus 400. This is called as intention to treat. But eventually, if some people in the team A has crossover to team B, or somebody has been left over, and so that the effective number has been significantly decreased, then with the remaining number, if you do an analysis, it's called as per protocol analysis. It means that you are analyzing people who just obeyed as per the protocol. That's called as per protocol analysis. The difference, we already know that in intention to treat, it's going to be a real-time situation where you offer a treatment for 10 families, 8 will accept, 2 may not accept, right? So this is going to be a real-time situation. That is what is by intention to treat analysis. It's an adapted trial design, meaning eventually during the due course, if you feel that you can change the sample size, you can change the inclusion criteria from 80 years of age to 90 years, all these things can be effectively done in this trial. So this is called as an adaptive trial design. Okay. So, or if you see there is a treatment arm or an adverse effect arm which has only 1 or 2 people, you can effectively lose that arm also. You may not consider this arm also. So you can do adaptive changes in your particular design so that maximum benefit is obtained out of this trial design. So allowed sample size is around 150 to 500 patients. Pre-specified endpoints of enrichment or modification of inclusion-exclusion criteria is being done. This trial was stopped in the first planned interim analysis. Therefore, no modification to inclusion-exclusion criteria had been performed on a later date. Okay, because it's in interim analysis, it's stopped. So, what is the meaning of interim analysis? Interim analysis is one when you have a trial conducted in a large group of population, say around 1,000 people with around an year you're going to do. In that case, you can analyze your results when you have recruited already somewhere around 400, 500 population, and you can do an interim analysis. And if you find that your treatment or your intervention is grossly beneficial or is going to be grossly harmful, including mortality or gross morbidity, then you need to stop this trial right there and do what is more beneficial for the patient rather than allowing the next 500 also to suffer, knowing that this particular treatment is going to be harmful or grossly beneficial. So this is the reason for interim analysis, and this particular study was stopped in the first interim analysis itself because of positive benefits. Okay, and this is funded by Stryker Neurosciences, who supplied the thrombectomy devices and performed a data analysis with oversight from independent statisticians.